Good afternoon. I hope you all enjoyed your lunch and are ready for an exciting afternoon session. I'm Sarah Gardner. I'm a clinical lead from Community Tissue Viability Service in Oxford, but I'm also a TVS trustee, and I'll be presenting. I'm multitasking this afternoon, so I'm going to be presenting the first session this afternoon, but also will be chairing the session as well. So I'm going to start off by talking to you about an experience that we've had in Oxfordshire about introducing a pathway, venous leg ulcer pathway, to improve the healing rates of our venous leg ulcers. Just a little bit about myself or my team. This is Oxford, for those who haven't been, and this is my team. We have 2 administrators, there are 4 tissue viability nurses, and myself as a clinical lead. We cover a population of, it's actually just under 700,000 people now, county-wide service, and we offer specialist advice to a wide range of clinicians, so including community nursing teams, who probably are predominantly our biggest sort of workforce that we support. Practice nurses, community hospitals. We are now an integrated trust with mental health services, so we offer support to mental health as well. We offer a sort of daily coordination service in terms of email advice. I don't know about you folks, but previously we were always playing phone tag with people when they're wanting to ask for some advice or support. So we now offer a service where people can email in. We have a daily coordinator who triages and deals with those emails on a daily basis, so people can get sort of quite rapid support. We've also started introducing some telemedicine. People can FaceTime from the patient's bedside, as it were, speak to the coordinator, and we can give them some instant advice. We also run a county-wide equipment service as well, so that keeps us very busy, and we deliver a very large educational programme to a wide range of clinicians as well. So when I think about my team, we are quite innovative, and we're very passionate about what we do. But when you look at, I don't know about you here, but the other day I was up in Gloucestershire only at the weekend and opened my camper van curtains and couldn't believe my eyes when there was snow outside. But when you're talking about snowmen, this is a nice little sort of analogy of some teams, district nursing teams or tissue viability teams, are quite happy to go with the status quo. You know, they're good at what they do, however, to sort of think outside the box or to be a bit more creative is too much like hard work with everything that's going on. But for us, this is my team, it's all about the passion, and what's quite scary is actually this was a snowman or a snow lady that one of my tissue viability nurses put together. So it is about passion. We are passionate about what we do, and we're always trying to look at ways of improving things for our patients. So what started us along this track then of our leg ulcer pathway? Well, these are just some photographs of patients that we had been caring for in Oxfordshire. You know, I think you look at photographs like this, and if you put yourselves in these patients' shoes, you know, you would want something done about it. Living with leg ulcer is horrific in many ways. The poor quality of life, the pain, the smell, reduced mobility, the social isolation. And these wounds, they remain unhealed for months, for years, for generations sometimes. And I think sometimes there's a complacency that that's about as good as it's going to get, and it's unacceptable. We have to do something about it. So being faced with these sort of scenarios when we had referrals into our service, we knew we had to do something about it to improve things for our patient. I know that when Heidi was speaking this morning, she mentioned, was it from the guest paper, that there are £3.2 billion spent on unhealed ulcers, leg ulcers. So that, again, is a starting point, isn't it? We need to be doing something about it. It shouldn't just be about cost, but we know it has to be about cost. So it's cost in terms of quality of life, but cost as in we need to be making savings to the NHS. So nationally, when we look at leg ulcers, we have a prevalence of approximately 1.5 per 1,000 of the adult population. And that increases as patients get older. And as you know, we have an ageing population now, so the problem potentially could only get worse. very old statistic here, but as we know from the guest paper, leg ulcers are very, very costly. And when we look at healing rates, we should be aiming for healing rates of between 16 and 24 weeks, and that can be generous. But I'll go on to tell you about our healing rates in Oxfordshire and what prompted our pathway. But we know that in leg ulcer management, these wounds fail to heal in a timely, orderly way, and that can be for a range of reasons. And studies show that there is not always correct treatment in place, and people fail to refer on to specialists. And I don't know, try to understand the psychology behind that, but sometimes it's the wood and the trees, isn't it? You're so busy out there that actually 6 months, 9 months has gone by, and you haven't realised, well, you haven't really sat back and thought this wound has not progressed on. There's no trigger in place to refer that patient on. I think the lack of continuity of care, we have patients that comment that they don't see the same nurse twice. These are other reasons, for people not taking the responsibility for referring that patient on. So back in 2011 and 12 in Oxfordshire, we did some audits and we found that these are sort of numbers that we were dealing with. They're not huge numbers. Some of you will come from much bigger counties, some will come from smaller counties. But at that moment in time, we found that we had between 402 and 427 patients with a minimum of 1 ulcer. And in line with the usual stats, the majority of these were deemed to be venous in etiology. We didn't have healing rates, we didn't have measures in place at that time that measured healing, but we calculated wound duration at that time of the audit. And this ranged across those 2 years from between 12 and 24 months. So this is duration. These are not healed within that period of time. Wound care at that time was actually 50-50, which is an interesting statistic. I think historically we always found that district nurses undertook most of the leg ulcer management, but certainly in Oxfordshire it was balanced at 50-50. These days, if the patient can get their big toe out the front door, they have to go to the treatment room. That's another conversation, another debate. We did some sort of analysis, costings-wise, with our finance department. And we calculated that the costs associated with leg ulcer care in relation to community nursing time was £368,500 per year. And we then calculated that if we could improve our healing rates and get people healed within 24 weeks, we could make savings of over £250,000. At that time, our prescribing costs were £1.6 million. And of course, not all of that was linked to leg ulcer management, but it's a shed load of money. So this is some local data. I'm not going to sort of go into any detail, but you can see that over those 2 years it was similar. We started looking at what was recurrent, and what was quite horrific is nearly 40% of our patients were recurring within, had a recurrent ulcer. It wasn't a new ulcer. And also, as you can see, over those 2 years, it was only just over 50% in year 2 were in high compression, when they could be in high compression, which again was a bit depressing. So we sort of tried to look at why this was happening. We'd been through some major organisational change. We'd integrated our mental health trust with our physical health trust, so there was a lot of restructuring in terms of management and leadership. And we felt that over a number of years there'd been a lot of skill mix put into the district nursing teams, and therefore you could argue there was quite a dilution of experienced nurses. We found that experienced nurses were going into tier 2 sort of roles and leaving district nursing. So, there was that, I suppose, dilution of good clinical leadership within the teams. Time and lack of capacity is always something that's quoted. I'm not saying people have got time when they haven't, but I think we can always make efficiencies on time. And I know that people glaze over when I say to them, if you get it right at the outset, get your assessment right, it will save you time. You get those raised eyebrows when you say that. But we know it's true, but it's trying to convince people that that's the way we need to do things. Lack of primary nursing. Again, patients, were quoting, I never seen the same nurse twice. And I think that lack of continuity. one, it doesn't get people into the skills, but also they can't see the changes and when they need to refer. We had poor attendance at our training sessions at that point. So again, if you haven't got people attending training, they're not going to be skilled to undertake the care. And we had policy and guidelines in place which people weren't following. Patients are more challenging. I don't know if you agree with that. And what do we mean by challenging? I think more complex. And I think, just the complexity of their comorbidities contributes sometimes to the ability to heal. What about accountability? I think nurses sometimes lose sight of accountability, and therefore we need to sort of revisit that and get them to take responsibility and accountability for what they're doing. And at that point, we weren't outcome-driven. If we're not being measured, we can get away with actually not, or not being responsible or accountable for our healing rates. At a patient-specific or wound care level, what we found when we did these audits is that there was a lack of robust assessment in place. So it goes back to, if you don't do a proper assessment, you possibly aren't getting the right etiology, therefore you're probably on the wrong treatment pathway. Definitely suboptimal bandaging skills in place. People sometimes think they're good at bandaging, and until they're assessed, they don't realise that maybe improvements can be made. Wound bed preparation. At the point of referral, we'd go out and see patients, and there'd be devitalised tissue in the wound bed, there'd be local wound bed infection, the wounds would be very inflammatory, and we know unless you can improve the wound bed and get those wounds out of that inflammatory status, they aren't going to heal. Patient concordance, and I'm not going to dwell on this because I could do a whole presentation on patient concordance. I think that nurses are responsible for a lot of non-concordance. If you'd like to see me afterwards and chat about that, I'm more than happy to. And I don't think we do that deliberately, but sometimes it's just we appear rushed, we haven't got the skills. I don't know, but I think we can make improvements on that. I think failure to recognise the risk factors for healing is a problem. And again, it's that delay in referral to specialist services. Pain is an issue, and I think people get nervous about stepping outside the norm when we're trying to manage pain, or don't recognise why a wound is painful. And of course, if we're going to a patient and we're wanting to put compression on them and they've got a painful limb, they think you're mad, don't they, when you want to put bandages on when their limb is so painful. So we need to get better at managing that pain. And I think we don't always fully understand that patient experience. I've been involved in a couple of investigations around leg ulcer management, some serious investigations, which was unheard of years ago, wasn't it? It always seems to be associated with pressure ulcers. But, what came back was that nurses didn't believe I had pain. They didn't believe it smelt so badly. And I think we sometimes need to put ourselves in the patient's shoes and understand it a bit more. So we had to do something about it. It was not good enough that we had these patients with open ulceration 2 years, 5 years, 10 years on. And therefore we decided to set ourselves a challenge. And we said to ourselves, and this wasn't a commission target, it was an internal target, that 70% of our venous leg ulcer patients would be healed at 24 weeks. So how were we going to do that? Well, we decided that we needed to introduce some sort of pathway, so a treatment pathway that was going to be standardised, and no matter whether you were a district nurse in the north of the county or the south of the county, you would follow that pathway, the patient would get the same care. So when you're talking about pathways, they can be called care pathways, treatment pathways. There's lots of different terminology, and pathways have been used in healthcare for many years in many different areas, not just wound care. And a care pathway is a model of care that reflects locally agreed standard based on available evidence. So when you ask a nurse whether they're practising evidence-based care, they sort of hesitate a bit. And would maybe struggle to cite a reference of a piece of research. But, if you're putting a pathway in place that has got the evidence behind it and they're following that, they will be practising evidence-based care, we hope. So lots of benefits of using pathways. It would ensure some equity and continuity of care, and hopefully it will improve quality and outcomes without impacting on spend. There wasn't any more money, so what we were going to do couldn't cost us any more money, and hopefully it was going to save us money. So hopefully there'll be improvements in productivity and the management of nursing capacity, so this should impact positively on our nursing capacity. So if currently they're visiting patients every day because their leg is dripping, hopefully because of the improvement they'll be able to visit less often, which will free them up to do other things. Hopefully it would reduce healthcare complications. A lot of these leg ulcers become infected. We know patients ended up being admitted for IV antibiotics. Hopefully it would prevent those sort of problems. It will improve documentation and also reduce organisational risk. As I said, I've been involved in a couple of Syria investigations and people, there is litigation, isn't there, around poor healing rates. And it also would encourage multidisciplinary working. This is about, we all have a responsibility, so it's how we work with GPs to manage our patients with leg ulcers. It's not just a nursing problem. And it can be outcome measured, so hopefully we can start getting some data that proved by implementing a pathway we are improving the healing rates for our patients. But you need to be a bit cautious also, or a lot cautious really. For those of you that are designing the pathways, you could be held liable if patient harm occurs, so it's not just, I fancy putting this together and I'm sure that will work. You have to make sure that there's the evidence behind what you're doing. We got our pathway signed off by governance, it went through all the right channels. But as we know, it's a bit like taking a horse to water, isn't it? You can have the best pathway in place. It doesn't necessarily lead to automatic change. You have to look at change management strategies as well, about how you're going to get it embedded into practice. But it's really important that it just doesn't become a set of rules. Clinicians need to see the value of what you're doing or what this pathway sets out to achieve, rather than always just another tick box exercise. So our treatment pathway, we had an inclusion criteria. What we decided to do was we had to run a pilot first. We had to demonstrate that the pathway was effective before we rolled it out. So we took a sample of patients, and rather than taking the whole sample from the audit, which included practice nurse patients, we kept it small. I'm a great believer in sort of following the sort of quality improvement methodology and keeping your sample size as small as possible. So we took just the patients with a venous leg ulcer that had been diagnosed by the clinician looking after them. So in this case, it was district nurses. So from our district nursing cohort. The patients had to be currently in high compression or were willing to go into it. And they had to be willing to go on to the treatment pathway. We know some patients have their favourite treatments and might have been reluctant to change, so there had to be a willingness that they did that. And the patients couldn't be under the care of secondary care at that point because we need to sort of have some sort of control over what we were doing. So the pathway design was based on the criteria for the AQP venous leg ulcers document, and we developed two pathways, a standard pathway and a complex pathway. So this was a standard pathway, so it was a first ulcer for a patient, it was a younger ulcer, so it's less than that 24-week period, so less than 6 months. Smaller, so you'd say, well, 100 centimetre squares isn't very small, but it was also accumulative, because sometimes patients have a number of ulcers together, don't they? And they had less than 3 episodes of local wound infection in that period of time. And the complex pathway was the opposite of that, so they're bigger, older, maybe more infection, and if it was a recurrent ulceration, we automatically put them onto the complex criteria pathway. So the pathways have a focus on wound bed preparation. As I said earlier, it's getting it right from the outset, so it's giving that wound the best potential that you can give it, really. So you need free from devitalised tissue and infection. But also the focus for the pathways was the potential for having elevated MMPs. So these more chronic wounds had the potential for that. And that's we based our hypothesis on that in a sense. Compression was based on patients' level of mobility, but also the acceptance and tolerance of a bandage system. In Oxford, we have 2 bandage systems. We have a short stretch system and a 2-layer system. And even though we based it on level of mobility, it had to suit the patient. And we know, that is really important if we're going to get concordance. And the key thing about the pathway, it's based on 6 weekly milestones. So there's a lot of evidence out there around wound progression over 4 to 6 week period. So we took a baseline measurement in centimetres square and we were aiming for a 40% reduction at 6 weeks. And I'll go on to talk a bit more about that in a minute. And this failure to progress at 6 weeks, if that was the trigger, that it would trigger a referral to tissue viability. We didn't want people hanging on to these patients for longer than 6 weeks. So this is just a table really setting out our standard and complex. So depending on which pathway the patient was on as to which products we used, if you see what I mean. And so the standard pathway was very much just a simple contact layer, absorbent pad based on level of exudate and compression. And then the complex pathway, we made an assumption, rightly or wrongly, but it worked for us, that these chronic wounds, which were greater than 2 years old, had elevated MMP, so we used a protease inhibitor as our baseline contact layer, together with your absorbent pad and compression system. So when you're thinking about implementing a pathway like this, you know, you need to be thinking thinking ahead really about. I'm a great believer in, I think I'm a bit of a glass half empty person. And I like to be a glass half empty person because I always think of what things that might go wrong so I can think of solutions to them before it happens. But I think it's important that you engage with staff at an early stage. So you need to be communicating what you're intending to do. Get them on board, get the ideas going, because then you can look at the barriers that might be put in your way, because you need to be addressing those barriers if you're going to succeed. So good communication is essential. Education and training was a massive feature of our pilot. You know, we had to make sure we sort of educated in terms of diagnostics, but also your skills such as bandaging. We needed to listen to any concerns or feedback, and we need some realistic timescales. You know, there's a great, I don't know about you, but we just get pressure put on us all the time is, oh, just roll it out, get it out there now. We know that it has to be the right time. You can't hold back, but it has to be the right time for your workforce to be making changes in how they work. So we had a steering group, and we had buy-in from senior management. That was really important. We developed the pathways and the resources that supported that. We got all that in place. We made sure we had patient information leaflets about the pathway, because it's really important that they understood why maybe their treatment was going to be changing, so they could be part of that discussion. We had to set up our database to get our results onto. We had a rolling education programme, and what was key to this pilot, and it remains to be a key bit of our success, is, have you all heard of patient status at a glance? It was part of the Productives model from years ago. So every time I do this presentation, everyone looks at me blankly, and it is a national. Has anyone heard of patient status at a glance? Yeah? So it's a very visual display of things that can be risky. It was used a lot in pressure damage, but it's a display that nurses would have on their walls. So all their patients who were on the pathway would be displayed on this board with your 6 weekly milestones. And what it does is you're meant to sort of stand by your board once a week and make sure that everything that should have been done has been done. It's a bit of a checklist, but because it's in your face, because it's on the wall, it's not hidden like in an IT system. And I'll mention that again in a minute, but we had to get that set up. And we had to have key communication with GPs as well, because of obviously addressing pain, etc. So training, this is who we trained. Lots of nurses, and we did 3-hour sessions, lots of bandage training, and we had a big support from industry. I'm just aware that we're meant to have a traffic light system here, and I'm thinking, oh, I'm doing really well, I'm still on green, but I've just looked at my watch and I shouldn't be on green. Should it be changing? Anyway, so what we did as part of the training, we also did some bandage training, but also because the focus is on surface area reduction of a wound. Nurses weren't used to sort of working out surface area. It's mainly longest length, widest width. So it involved maths, and I'm not very good at maths. I got CSE grade 3, I think. But we did a document, like a guidance on how to work out surface area, because that was key to this. So there's lots of practical stuff that went on. So we had a pilot pathway timeline. And as I said, that was based on 6 weekly measurements. I'm just going to speed up a bit now. So the data expected to be submitted by the clinicians involved in the study was they sent in their baseline data. So those patients that were put onto the study, they submitted their baseline surface area of their wound, the date they were put onto the pathway. And then every 6 weeks they sent in updated information on wound size. If they'd been healed in that period of time, they told us they were healed. If they'd been taken off the pathway, we were told why they'd been taken off the pathway. And this went on over the 24-week period. And at 24 weeks, if they weren't healed, we got their final surface area measurement. Basically, some patients were removed from the pilot. Non-concordance, we did say 2 hits and they're out, so we gave them 2 opportunities to try and explore why they wouldn't concord with treatment. But I felt that there were some patients who were desperately quite poorly with comorbidities and couldn't tolerate compression because of that. So there's a number of reasons why patients were removed from the pilot. So at the start of the pilot, we had 77 patients who were part of this study. And as you can see, because of the wound duration, most of them were allocated to a complex pathway because they were in excess of 6 months old. And these are the figures, really. So out of the 77 patients, 31 healed within 24 weeks. 10 patients had improved greater than 70% at 24 weeks, and we had a number that was static, and there was, how many is that, 27 that were removed from the pathway. And these are the main reasons why they were moved from the pathway. What was quite worrying is some of them weren't even a venous leg ulcer, so they weren't getting that etiology right from the outset. Some of them because of poorly controlled comorbidities. So the challenges we had was, do you believe what you've been told? So it goes back to, if you've been told that these are venous leg ulcer patients, you have to go on what you've been told, but obviously we concluded that the etiology wasn't right in all cases. There were inconsistencies in knowledge and skills of community nurses. Getting the data was tough. And we're competing all the time with other pressures. Any study that people are carrying out, you're always competing, aren't you, with other things that are going on within the organisation. So when we applied it to those that completed the pathway, we did achieve our 70% target. You know, there was a chunk of patients that shouldn't have been on. They weren't venous from the outset. Those that were purely venous, 70% of those did heal at 24 weeks. What didn't work? Well, we couldn't actually map the speed of healing because we didn't get that data consistently every 6 weeks. We sort of got at the beginning and at the end. We didn't know. Did wounds have a rapid healing and then slow down, or was it a slow then sped up? It would have been nice to have mapped that, but that's the difficulty when you're relying upon other people to give you data. So the concerns were the high number having to be removed from the pathway and those being treated as a venous leg ulcer when they clearly weren't. Comorbidities not being managed to an optimum level was a concern. You know, and I would question what the GP's responsibility is in terms of supporting you in optimising the patient's health, certainly in terms of things like diabetes or some of the cardiac issues or respiratory issues and pain. And some patients are very, very complex, and I just wonder why they hadn't been referred to tissue viability before, but I suppose we hadn't got a pathway in place then. So what's happened since? We've now got a full rollout of the pathway to all community nursing teams, and we are consistently achieving our 70% healing at 24 weeks, well within that actually. GP service now has a leg ulcer specification based on the pathway, so that's really good news that we've now got practice nurses using that model as well, and we're seeing some really good improved healing rates on the back of that. The patient status at a glance model has now been implemented across the county, and certainly those teams that are using it properly appear to have the better healing rates. So I would recommend that that is looked at by those that are interested in it. And the pathway now forms part of our leg ulcer training. And we're I've just drafted a mixed etiology pathway, and we're about to audit and then start a pilot on a mixed etiology pathway from June of this year. And that's me. Thank you very much.